Healthcare Boulevard, welcome back. I am here for another interview, the first one in a while, and I'm very, very, very excited. I have here Sunny, who is a CAA. I know you're like, what is that? In case you're like, well, if you know what that is, you are way ahead of me, and I'm so proud of you. Okay, I'm very excited to learn about him, what he does. So, Sunny, please go ahead, take the mic, tell our listeners who you are and what you do.
All right, guys. Well, my name is Sunny. I am a CAA. And what that is it's a certified anesthesiologist assistant. What CAAs are is that we are anesthetists that work within the anesthesia care team, and we provide anesthesia services for patient in a very similar, if not identical, capacity to a CRNA within the anesthesia care team. That includes induction of anesthesia. We will intubate the patients. We'll maintain their hemodynamics and watch their vital signs, making sure that everything, the depth of anesthesia is adequate, the paralysis. We do the full spectrum of anesthesia care from cardiac surgery to neurosurgery, high risk OB, regional and interaxial anesthesia. We are a very quickly growing profession of advanced practice providers in the United States. I think since I graduated school, we've doubled the number of schools and doubled the number of CAAs as well. So this is a very quickly growing profession, and we're very quickly gaining a lot of traction online too.
Mm-hmm.
Um, I love what I do. We play a huge role within healthcare and within surgery, and I couldn't recommend this career enough to people. Um, but yeah, it's a great career. That's kind of a quick and dirty of what we do.
Yeah, it's interesting because I actually found out about you on TikTok. It's funny, I spent so long not understanding and not being on TikTok, and now
Yeah.
I'm there. And this is how I found you. I was literally just scrolling through TikTok for my 5 minute TikTok dose, and and then it was like, oh, I think it was one of the videos of you talking about, how much you make as a locum CAA. And
Yeah.
I saw the numbers and I was like, that's MD number. In fact, I know a whole lot of MD and even making that, depending on the specialty, of course,
Yeah.
right?
Oh yeah. Yeah.
So I was like, who is this guy? He's definitely in healthcare. What is his profession? How is he making that much? And how come I've never heard of him?
Yeah.
In I go on his DM, please let me interview you.
Yes. So I'll kind of break down some of that. So
Yes,
let me go through. Do you mind if I kind of explain how, like, the educational path first, and then
that's
going into the
exactly what I
jobs?
was going to ask. So you are ahead of it. Tell us.
Yeah, perfect. Thank you. So
Yeah.
the very similar to what you do, the CAA education model is the medical model of education. So what that means is that the CAAs must first have a pre-medical bachelor's degree with a required pre-medical curriculum. That includes, your biology one, biology two, your physics, your anatomy and physiology, your organic chemistry, your biochemistry, your statistics. The list goes on, all the typical pre-medical courses. The MCAT is typically required, or the GRE as well. Um, there are a few new schools that are requiring a new test called the Casper. Most of the students have a fair amount of patient care experience prior to coming to CAA school, very similar to PAs as well. Um, we require 8 hours of shadowing through documentation via a shadowing form, whether that be a CAA, an anesthesiologist, or a CRNA even within the
Okay.
anesthesia care team.
Okay.
Upon graduation from your undergraduate degree and having those things completed and getting accepted, you're going to attend a CAA school, which is anywhere from 2 to 2.5 years. The students average about 2,500 clinical hours during school, and hundreds of cases. So they're very prepared before they graduate as well.
Mhm.
Um, Now, one thing that I really want to like make note of to people is if we once we go into pay, once we go into the career, once we go into the workplaces, um, it is very difficult to get into school, just like PA school. The school that I attended last year, their matriculation data from last year, I graduated 5 years ago, was a 3.82 uh, cumulative GPA, a 3.82 science GPA, and a
Mhm.
510 average MCAT. So these
Mhm.
students are very, very competitive, very elite students. Now, the pay that you can expect as a permanent W-2 person, the base pay is anywhere from 250 typically to $300,000 for just your base pay for new grads coming out of school. I did a quarter 4 salary report on my TikTok where I just want to make sure I recently verified these numbers. And the quarter 4 data came out from bagmask.com. That's one of our main job boards.
Okay.
They were kind enough to release this information kind of in a digestible format for us. And it was pretty fascinating to see how much these new graduates are getting paid,
Mm-hmm.
particularly in states like Washington, where the new grad average salary is above $300,000 for kids starting out of school with
Nice.
no overtime, no bonuses or anything. Now the locums market, the locum CA work is what I've been doing for the last couple of years. The
Mm-hmm.
pay for that is anywhere between $200 to $300 an hour, base, depending on your shift. So it's not uncommon for locum CAs to be making more than $500,000,
Mm-hmm.
to $800,000 now. I made
Mm-hmm.
655,000 last year, as a locum CA, and I was working my butt off to get to that
Mm-hmm.
number. But
Mm-hmm.
it's out there. It's an available career. You can provide for your family. The reason why it's like that, and the reason that the pay is so high, is that we're currently in the perhaps the greatest anesthesia shortage in American history. We're having to cancel surgeries across the country because we simply don't have enough anesthesia providers, and so that's also one of the reasons why my profession, has kind of proliferated and exploded over the last few years. Is we just simply need more anesthesia providers, and CAs are here, and we're trying to grow and trying to expand into new states as
Mm-hmm.
time progresses. But I mean, this is an absolutely amazing career. I love what I do every day. The pay catches people's attention right away,
It
and
caught mine.
yeah, and from there, it kind of allows us to have these conversations about what is a
Yeah.
CAA, like what do we do, why, like let's talk about some of the cons, because there are definitely some cons in this career as well if you have time.
Mm-hmm.
Um,
Please, yeah.
so CAs can only practice currently in about half the states in the United States. Okay.
Mm-hmm.
This is something that needs to be mentioned, something that needs to be identified by people. And why is that? Well, CAA as a profession, we're only about 5,000 strong currently. There are not a lot of CAAs within the United States. None of these numbers are projected to quickly grow. We have explosive growth right now. The number of schools is doubling. The number of seats within the programs is growing as well.
Mm-hmm.
Um,
Because the need
so
is there, right? So
yes,
yeah.
we have a severe need. We're in a severe shortage. We have to grow. We have to create more CAAs. In order to work in a state, a CAA has to come up with a grassroots effort to convince legislators to create essentially a law allowing CAAs to practice. And it simply
Mm-hmm.
hasn't happened where we've been able to do that in all the states because we don't have a lot of CAAs. So there just hasn't been as much effort put into legislative growth because we really haven't had to, because we've had plenty of jobs within our restricted geographic area.
Mm-hmm.
Um, Now that's very quickly changing. We still have plenty of jobs, but as the number of CAs grows, there are kids that are from states where CAs can't practice, and now they're going out and they're starting these state academies and they're helping grow the profession. Um, the job outlook in this career is amazing. So I think this was back before the anesthesia shortage was even big, before COVID. I had 6 job offers before I graduated school. The current students, they have unlimited job prospects. And in the current market, I make this joke all the time, but it's not really a joke. If you have a pulse, you have a job. So you can go and work in almost any hospital that hires CAs as long as you are alive and as long as you have your certification, you have a job there. So
Yeah. Yeah.
uh, it's a very easy way to get employment. You're never going to be short for work in this profession.
Mm-hmm.
But what specific questions do you have for me that I can answer for you?
Yeah, so you actually answered a lot of them. And first of all, let me say thank you for the pay transparency. I've noticed more, being more present on social media myself as a provider. I've noticed more providers, and even nurses and other healthcare professionals choosing to be transparent with their pay. And that's something that I've also noticed some of them, perhaps all of them, are getting some scrutiny for,
Oh, absolutely.
because I think as a profession, because we are in the business of caring for other people as
Yeah,
healthcare people, a lot of time we are expected to sort of hide our need to feed ourselves and our families, our need to say, hey, yes, I'm here to care, but also I also have needs. My bills are not going to get paid from, just my big old heart or my compassion. My bills are going to get paid by how much is on that paycheck once I get it at the end of the day. You know what I'm saying? So
absolutely.
we are just like anybody else in terms of when it comes to our profession, we do desire and we have the right to want to have to make big money, especially for the all the amount of schooling,
Yes.
on scrutiny,
Yeah.
stress, and everything that goes into majority, if not every healthcare professional's journey before they get that certification. So I've definitely have appreciated seeing more nurses, more doctors, more NPs, PAs, CONAs, CAs. I've seen more healthcare professionals being open about it, despite knowing that they're going to get scrutiny by people in the comments saying, oh, you only care about the money. Just because you share your income, just because in trying to encourage other people in becoming your profession and joining your profession if they are interested in it, or just educating purely, doesn't mean you're all about the money. You know what I'm saying? And you know that.
Of
um
course.
but
And
yeah, I just wanted to say thank you for that transparency.
of course, and it's imperative that we are transparent about this. It's imperative that we explain to the next generation of healthcare providers where the market is, because the education for our programs, yours and mine, are extremely expensive.
Mm-hmm.
CAA school, these students are averaging 150 to $200,000 in student loans when they're coming out, and if they don't understand that there is a light at the end of the tunnel, you can still pay that off. You can still provide for your family, your newborn daughter.
Yes.
You still can have an amazing career while paying off this insane mountain of debt.
Mm-hmm.
They're not going to pursue them.
Exactly.
And this is just good. It's simply good for the next generation of providers. We need to be transparent. The only people that benefit from healthcare providers not being transparent are the corporations that employ us.
Mm-hmm,
So,
mm-hmm. Because
um,
what that does is that increases the likelihood that somebody, especially a new grad, and even experienced somebody, not a provider, not knowing that, what the next door neighbor in
mhm.
terms of the next door colleague is making, accepting a low ball offer, right?
Yes, yes.
And it's they're going to give you a low ball offer and look at you and smile at you. It's business. So just like they have to protect their own in trying to get the best service for the lowest cost, you have to make sure that, hey, let me educate myself on not just what the average pay is, but what really is the budget open for, right? How
Yes, ma'am.
much can I truly get? Because the reality is, if you do come out off the bat getting paid well, you are more likely to stay in that place, because people talk about retention.
Mhm.
If you're paying your providers well, they'll and treating them well, they're more likely to stay.
Yes, 100%.
It's
Absolutely.
like it's
Yeah.
common sense, but sometimes it's hard to like
Yeah.
convince or like get it through to some of these higher
Yeah.
management team that, hey, hello.
Yeah.
you know
Yeah, no, 100%. And I mean, it's a topic that's very important. And obviously, you notice in the comments, I get a lot of heat for this.
yes.
You've seen the comments on these posts, and I just leave them, and I don't engage with them. But because I'm not that person is not my target audience. My target audience is that pre-med student who's thinking about making the jump, and I want that person to know that it's going to be fine. And
Exactly.
I don't really care about the other people or the people that are arguing with me. So I just leave it be.
Like, it's not
Yeah.
for you. Just move on. Keep on to the next call.
Yes, ma'am. Yes, ma'am. Absolutely, absolutely. But no, I mean, this is a great career, but yeah, I love
Yeah.
it. I love it. I do some W-2 work. So
Okay.
I do some Nighthawk work where I do 26 weeks of Nighthawk, primarily obstetric anesthesia. And then
Okay.
I travel to Indiana. I'm doing a week a month of locums there.
Okay.
And it's the best schedule ever. I love it.
Nice.
I'm on my
Nice.
week off right now, so uh,
Uh-huh.
it's great
Nice.
just having a week every month to
To
decompress.
just
But
decompress.
yeah,
Now, I would like to go back a little bit and learn a little bit about the history of CAAs. And
yeah,
also, your background is in the military, is my
yes,
understanding. So tell us a
yes,
little bit about the history of CAA, how you found out about this profession, and if
yeah.
there's any connection between that and your background as a vet.
Of course. So, CAs were started in 1968 at
Mhm,
Emory University in Atlanta, Georgia.
mhm,
It was created by a group of anesthesiologists with the goal of creating a more tailor-made anesthetist, anesthesia provider that could be directly educated to becoming an anesthetist. At the time, the only anesthetist in existence was the CRNA,
mhm,
and that was a kind of long route to like kind of jagged route to becoming an anesthetist because you had to go get your bachelor's of nursing and then work in the ICU, and then you go to CRNA
mhm.
school. So it wasn't this direct path to the medical model, which is what we're all used to create an
Mhm.
anesthetist. They did so at Emory University shortly thereafter. I want to say in 1969 or 1970, Case Western Reserve started a school as well. They were the first two schools. For a long time, there were not very many schools up until very recently. And they started tailoring and honing this profession and started learning how to create these AAs. And over time, they have made extremely safe CAAs. They have kind of perfected this educational pathway to make
Mhm.
AAs. It's taken a long time. Um, but, you know, AAs are just as safe now or safer than CRNAs in the anesthesia care team according to the Stanford. We have one study on this. It was done at Stanford, we had 433,000 patients, and with 30-day mortality, perioperative length of stay, and cost, CAs were as cheap, as safe, or the patients stayed shorter periods of time
Mhm.
to CRNAs. So they're safe. We are completely interchangeable within the anesthesia
Mhm.
care team, and now that we've had this shortage and we've kind of honed this educational pathway to making these great APPs, we're quickly expanding the number of schools, quickly expanding the number of education programs, and spreading throughout the country. So this is a very, as you're aware, not a lot of people knew about it.
Mhm.
More and more people are becoming aware as this profession is growing, and it may be one of the fastest growing professions percentage wise in the country right now.
Yeah.
So, but yeah, my background. I grew up on my father is he raises cattle. He's a Red Angus rancher in eastern Montana and Glendive, Montana. And
Nice.
I grew up on his ranch and working with him. After high school, I decided I wanted to serve. I didn't really know what I wanted to do, so I joined the United States Marine Corps. I served as a Marine. I didn't, I just was like a normal Marine. I was all full of, patriotism, and I thought I was going to go and serve my country. And very fortunately for me, I didn't go to war. I was very lucky. At the
Mhm.
time, all I wanted was to go to war. But then, as you progress, you realize that's not necessarily a good thing for you.
Mhm.
I got very fortunate. I earned my GI Bill. I got out of the United States Marine Corps, and I attended the University of Arizona, where I majored in medical physiology at the Banner University, which is a medical school at the University of Arizona. They actually have an undergraduate major, their medical physiology major. I majored in that there. I did well in school. I worked in a microvirus lab working on bacteriophage all through my undergrad years. Ended up getting one publication when I was an undergrad that helped me get into AA school, and I volunteered at the VA while I was in school as well. During that time, I actually I was a competitive jiu-jitsu fighter, and I won a world championship, IBJJF blue belt adult heavyweight nogi jiu-jitsu tournament, and being able to throw that on your application helps too.
I
So
mean,
all these little
yes.
things, all these little things contributed to
It
me getting into
sets you
school.
apart, right? Because
Yeah,
everybody's gonna have that GPA and that educational background and everything else, and have a good written personal statement. So yeah, it sets you
people
apart, definitely.
people love it, and that's what I tell these guys is like, hey, even if you are like a badminton player, right? Say you're like the best badminton player in the county, right?
Yeah.
Make sure you put that on your personal statement. Like even if you're like whatever, if you like to crochet, put that on your personal statement. Tell people about you. People want to hear about what you like to do. They want to know about your like weird little hobbies like jujitsu or crochet. You know what I mean? People want to
Uh-huh.
know about it, and people like
Hmm.
that stuff. It helps you get in.
Yeah.
It helps them relate to you. But yeah,
If
that was kind of
nothing else, it's like, that's an interest. I'd like to hear more from him or her,
yes.
right?
Funny thing, during my interview for AA school, there's a program director now at in Joplin, Missouri. She just started the program for Kansas City University. She wasn't the program director of my school. She was just a faculty member at the Indiana University School of Medicine's AA program. And she was one of the people who interviewed me during my AA school interview. Her name is Sally Mitchell. Okay. And Sally interviewed me, and she saw on my application that I grew up on my dad's ranch. And
Mm-hmm.
she goes, and I'm in AA school, in this AA school interview. I'm so nervous, right?
Oh
I
my
don't know.
gosh, I can
I don't know what to,
imagine.
it's
I've
horrible. I
been
don't know what to
there,
expect.
right?
Yeah. Oh my God. You've been there for your PA school interviews. And I'm sweating through my suit. I've got my tie on, and I'm nervous. And she goes, it says here that you grew up on your dad's ranch. And I was like, yeah. And she goes, oh, okay, great. It means you're not going to have any problems waking up in the morning. And I got to tell you something. I love goat milk. And I was like, you do? And she's like, have you ever milked a goat? And I was like, I actually have milked a goat. I have milked lots of goats.
Yeah.
And she's like, tell me about that. And I sat there, I'm not joking, for 10 minutes talking to her about milking goats. And that was, and she, and at the time, I'm like, I didn't get in. Like, I 100%, I didn't
She
get
doesn't
in.
want to know anything about the medicine. She just want to know about goat milk. So
Yes,
clearly, right?
that's what I thought. And then, but then, like, looking back, I'm like, no, she just wanted to see if you could talk about something. She wanted to know if you could, like, be interpersonal in the operating room. Like, this was just a test, and it could have been any other topic. It could have been, crocheting, like I said earlier, or
Mhm.
anything in the world that was in my personal statement. She would have taken it and directed it to that path. So, when you guys are, right, when you guys are applying, put something about yourself and just be able to talk about it.
Yeah.
It just opens the door. It opens the
And
door.
that's interesting because I know more and more like the younger generation is arguably better at this than perhaps we were. But it's really just living your life to the fullest, right? The best
Yes.
way you can do that. Because sometimes, a lot of time, perhaps when we choose to go into medicine, we tend to focus, just be very tunnel vision. Okay, my volunteering has to be about medicine, right? I
Yep.
have to volunteer in the hospital. My work has to be like everything, even if I've already fulfilled all the requirements. Let
Yeah.
me we oftentimes we think if we do something non-medicine related that we are wasting our time, that it's not going to be looked at as a positive thing.
Yep.
Whereas if it's an interest of yours and you enjoy it, you are a person, right?
Yes.
Once you start working, you will do things outside of the hospital
Yep.
that has nothing to do with your profession. um
And people don't want robots that are just like hyper focused on one thing. They want to talk to coworkers that have other interests, right? And
exactly.
it's a great point. 100%.
Exactly.
100% agree with you.
Exactly. Okay, I love that. So, when did you hear about CAs?
So it was actually from a professor.
Mm,
Um, so I was like a student assistant kind of tutor thing for cardiac physiology because I was a physiology major and I'd taken this course, I'd done well, and the professor had was also a professor at the medical school, and at the time I was already married. I got married very young, and I wanted to get into a career where I could take care of patients and provide the best care that I could and provide for a family. And I went to this professor who I was this kind of preceptor tutor for, and I said, "Hey, ma'am, I don't want to be a physician. I know you teach the medical school. What are some other careers out there that are interesting?" And she pointed me towards perfusion. And she said, "And there's this other career that I know called CAA. Not a lot of people know about it, but she kind of just said it in passing. I've
mm,
never heard of it until then. So I went home that night and I started looking up perfusion and I started looking up CA. Both are amazing careers.
mhm,
And she I kind of like looked at the CA job and I was like, wait, they're doing anesthesia. They're full anesthetists in the operating room. How come I've never heard of this? I'm a
mhm,
physiology major. This is physiology at your fingertips. This directly translates from my undergraduate degree. I've never even heard of this profession, so I started looking into it more. At the time, there wasn't a Sunny out there talking to you guys about CA. There's
mhm,
nothing. And I'm getting on Student Doctor Network. I'm not joking. I'm in Reddit and I'm like copying and pasting like little sentences here and there, and I'm putting it in a Word document to learn about the AA profession. And then so I did that. There weren't even any AAs around me to shadow. I shadowed a
mhm,
CRNA at Banner Health in the anesthesia care team, and then I flew to Indiana for my interview, and I just regurgitated the information that people had told me on Student Doctor Network. It was a totally different environment of applications than we currently have. Um, and I got in. I remember they they actually asked me during my interview, like about the profession, and I think I even called my profession the wrong name. I said at one point. I said certified anesthesia assistant. If you say that today in an interview, you're not going to get accepted, right? If
mm,
you don't even say, I didn't even say the correct name of the profession because on some of the Reddit, things that weren't made by CAAs, they called them the certified anesthesia assistants. So I'd been reading the wrong name and no one had been correcting it
mhm,
because just weren't enough CAAs out there at the time to do what I'm doing, what these other online CAAs are doing currently. So it was just a very different environment. But now it's there's a lot of people out there that are producing content. There's a lot more information about CAAs out there. So and hopefully podcasts like yours can help kind of spread the word about these different I've noticed you have amazing professionals on here. I was listening to it last night. You have a lot of different people that come on your podcast and you're really exposing people to all these different professions, whether it's within the United States or Australia or wherever it is. people like you are kind of helping kids learn about new professions and even other medical professionals. It's wonderful work that you do. And I really appreciate
You.
it.
Thank you. And
So
that's exactly what I set out to do. Much like yours, in summary, I hadn't heard about the PA profession when,
yeah,
I was looking for what do I want to do. And much like yourself, I was like, listen, as a child, yeah, I thought about becoming a doctor. But as I go post high school and everything, I put all my interests together, what not just interests, but my priorities,
yeah,
right? And
yeah,
much like yourself, I was like, I want to be ready to start my family sooner than later.
yeah.
I want to be able to have that flexibility. So when I put all my priorities together, PA, once I learned about it, was like, mwah.
Yeah, that's
Was
exactly.
like,
Yeah,
ta-da!
yeah, 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 yeah.
You
And I
know?
mean, yeah, it's
And I'm
wonderful. And
so glad I found out about it. And so I was
yeah,
like, how many people could have had a great career and who have been a great PA, but
exactly.
never heard about it,
Yeah,
you know?
exactly.
And so that's why I started this after PA school. So
Yeah,
I'm very happy that we have more people like yourself and myself, other professionals, just putting the word out there. Hey, you have options. If you want to be an MD, go for it. Yes, we need more MDs, we need
of
more
course.
ODs.
Yeah,
If you want to be a nurse, go for it. There's always
mhm,
going to be a need for a nurse. But
yeah,
those two are not the only options. Those
yeah.
two are not the only things we need to run a good, healthy, and functioning, a medical system.
Absolutely.
So healthcare system. And so that's really the bottom line is you have options.
Yeah,
you
there's a
know?
lot of stuff out there. Yeah, there's a lot of stuff out there. But yeah, I appreciate you.
Yeah,
Um,
absolutely. So tell me something. Oh, just for the record, tell us exactly the full name of your profession, just so we get it
uh,
right.
so certified anesthesiologist
Okay.
assistant.
Okay, that's what I thought. Because certified
Yes,
anesthesiologist
you got it
assistant.
right. Yeah,
Okay,
yeah,
all right, all right. I'm like,
yeah.
okay, if you got it wrong way back then, let me make sure I got it right this time.
Yes. No, you did better than I did. So you're doing great.
So one thing I have learned is that there seems to be, I'm not gonna call it a clash, but a
Oh yeah.
lot of times there's this discussion about CRNA versus CAA. Now, mind you, as a PA, I'm not new to this discussion because I've seen left and right PA versus NP, PA
Yeah.
versus NP, PA versus MD, all of
Yeah.
this. So, but for
Yeah.
you, for your profession, the biggest thing is CAA versus CRNA. You
Yes.
alluded to it briefly in your when you talked earlier about the CRNA is the path, that path is a little longer,
Mhm.
but tell us, just do a little comparison for us, and then I have a few other questions about those two professions.
Absolutely, of course. So, um, starting with education. So CAAs, there are two models of education to produce advanced practice providers in the United States. What you and I are both familiar with is the medical model of education. So that
Mhm.
includes a pre-medical degree with pre-medical coursework. A lot of these students are doing research, volunteering in the hospital, like you were mentioning, patient care experience. You have to have excellent grades, excellent test scores. PA school and AA school are extremely competitive to get into. We are getting cream of the crop students, but we have PAs, we have CAAs, we have perfusionists, we have podiatrists, physicians even go for this model. MDs
Mm.
and DOs go through the medical model. You'll have optometrists, you have physical therapists, dentists, all these medical model professions kind of all follow this similar trend, and that is the pre-medical degree with all the experience you're doing at this time, your standardized test, and then your graduate school where you learn to do your profession, like work as a PA, work as a CAA, work as a perfusionist, work as a dentist, physical therapist, whatever there is.
Mhm.
In nursing, they have three main professions, I think only three actually, that follow this nursing model amongst all the APPs. Um, and that is going to be number one, the CRNAs, number
Mhm.
two, the nurse practitioners, and then number three, the nurse midwives. Now, what their pathway is that they go get their BSN, their Bachelor's of Nursing. Their graduate programs want them to get a couple of years of nursing experience in, and then they go to graduate school. For the CRNAs specifically, that's going to be BSN of nursing, 1 to 2 years of critical care in the ICU, and then they go to CRNA school. For nurse practitioners, it's the same thing, but it doesn't have to be the ICU. And for nurse midwives, a similar thing as well. Interestingly, there is no nurse midwife, in no direct comparison of a nurse midwife within the medical model.
The medical, okay, I got you. Mhm.
However, there is the CRNA and the CAA are very similar and absolutely compatible within the anesthesia care team. The nurse practitioner and the PA are very similar and compatible in almost all scenarios. And that's kind of the difference. Now, when it comes to length of education, one big difference between the CRNA and the CAA, CRNAs used to be a master's degree like a CAA until very recently, within the last few years. They've changed this to now they require a DNP or a DNAP in order to graduate. And what they did is they added 2 semesters of like nursing theory and research to get to that amount. Whereas CAAs, we don't believe that it's valuable for us to change from a master's degree to a doctorate yet.
Doctorate.
And we actually, as a profession, almost universally oppose that change. The big thing that's a difference in terms of practice. So the vast majority of CRNAs practice in the exact same capacity as CAAs. This is something that's commonly misunderstood. CAAs practice primarily, exclusively under medical direction. This is the most common form of anesthesia across the United States today. What this means is there are up to 4 rooms where it's CRNAs and CAAs and an anesthesia care team with one attending anesthesiologist overseeing 4 rooms. This is far and above the most common form of anesthesia. CRNAs, however, have decided that they want to practice independently, and it's primarily in some rural areas. So they have pushed very heavily legislatively to push to work independently in these small areas. And so a small percentage of CRNAs are going and working independently. As CAAs, we completely oppose that. We do not believe that we should work independently at all. There has never been a single movement of legislative effort by us to work independently, and there never will be. We are exclusively anesthetists in the anesthesia care team. We're going to stick with this model. It's the safest model of anesthesia until the end of time. And
it's interesting.
Yeah.
I see, like you saying, comparing the PANP versus CAA, CRNA, and it's pretty much like, very parallel
Yeah.
to the point where on my side of the aisle, we have NPs. NPs are more likely and have more freedom, so to speak, or independability in their way of practice, right? So
Yeah.
NPs can open their own clinic, and they tend to be able to practice singly without an MD supervision, legally speaking, better than us PAs. And there's just like a lot of loophole if we even want to do that. And a lot of time as PAs, we go in again. The word assistant is in our name. You know what I'm saying?
Exactly.
Now,
Yes.
Contrary to what some people who are not aware of our career may think, no, we are not medical assistants, right?
Yeah.
But we are, we do work with a physician, and much less of us are really striving for this. Okay, let's work for ourselves. Let's work for ourselves. Compared to the nursing side, so it's definitely a lot of mirroring in seeing the nursing version of your profession and the nursing version of my profession, and some similarity on that camp wherein they're more striving for the ability to work independently and succeeding to some degree depending on where you are in the country.
And when people that are less educated on the topic than yourself ask me about this political battle, I just use your guys' battle as an example because it's the exact same thing.
Yeah, and it's more non, like the NP, PA. Those are two professions that are a little more known than the CAA, right? Like PAs are more known nowadays, at least, than CAAs. So it's a great comparison. And more people are used to NPs. A lot of my patients have called me NPs, and I'm like, no, I'm a PA, but I get it.
It's okay.
Moving on. Let's take care of you.
Day. Yes, I know. Every day I get called a CRNA, and it's okay. I'm like, no, I'm a CAA, but it's okay. Like, you don't know. It's fine.
Quick correction, but let's keep going.
Yeah. But that's too funny. It happens to me every day. Yeah.
So I think you already answered this, but I do want to reiterate. So as far as when you're in the OR, so I want to get a better idea of what your role is in the OR. Of course, you're in the anesthesia team. Yes. I want to know, you mentioned one attending anesthesiology sort of supervising or being ready to answer any question, things like that, with
Yes.
4 different APP anesthesia. So are you in the room by yourself?
Yes. For the
Okay.
vast majority of the case,
Okay.
um, we are in the room by ourselves. Now, so in order to bill for a case under medical direction, if you guys want to get online, if you're listening to this and look up the 7 steps of TEFRA, that kind of breaks down what exactly is needed in order to do a case under medical direction and in order to bill for a case to Medicare and Medicaid under medical direction. Now, what that entails essentially is that the anesthesiologist must be in the case for the induction phase. So if we put an airway in, so either an LMA or an endotracheal tube, they must be in there when we place the endotracheal tube. So they'll jump in the room. They know everything about the patient. They'll essentially give us the thumbs up. We will induce the patient. We'll place the endotracheal tube. They'll make sure that the patient's fine, the endotracheal tube is placed correctly, and they just walk out of the room and we do the rest of the anesthetic.
Gotcha.
Now the anesthesiologist must see the patient in pre-op, right? And if there's any debate on the anesthesia care plan, whether like whatever they're say one person wants to do this, one person wants to do that, ultimately in order to bill under medical direction under TEFRA, the anesthesiologist has final say on
Mhm.
the anesthesia care plan.
Mhm.
Um, the anesthesiologist must also see the patient at some point during emergence, and that includes even into the recovery area. So some anesthesiologists will want to be there when you extubate. Some will just meet the patient in recovery. As CAs, we're doing everything. We're doing the spinals. We're doing regional anesthesia in most hospitals that I've worked in. And that's that. It's just we're just doing the entire anesthetic. An example of a case would be: Have you been in an opera? Have you been kind of in? Have you done any kind of like surgical work before?
No, outside of my training, no, I have not.
So as soon as we induce, I'll put the patient to sleep. He'll head out, and there's a lot of things that happen. So we have to prepare the patient for surgery now. I hook them up to the ventilator. We have a machine that's actually breathing for the patient if it's general anesthetic. It's also delivering some anesthetic gas.
Mhm.
We're watching tidal volume. We're watching our respiratory rate, looking at our minute ventilation, and as well as our end tidal CO2 to assess whether we need to breathe more for the patient or less for the patient. The end tidal CO2 is going to be an indicator of your body's carbon dioxide, so it just lets us know how much to breathe for you. We're going to also be giving you pain medicine throughout the case, nausea medicine throughout the case. The big role that we have is watching and monitoring hemodynamics. Almost all the medications that we give you are direct myocardial depressants and vasodilators. So it's very easy for the patient's blood pressure to absolutely tank during anesthesia. So we're doing things to watch that, whether that's we give different vasopressors and inotropes based on the situation, based on what's happening. So we're looking at kind of what's happening in the clinical picture, and we're treating blood pressure based on that. In larger cases, we're giving blood products. We're monitoring arterial blood gases and adjusting what's needed. With that, just the full spectrum of an anesthetic we are providing as CAAs, and we at the end of the case we're going to hopefully, if it's not like a trauma or like a very sick patient, wake you up, not leave you intubated, not take you to the ICU, but wake you up, and there's a whole series of steps that we do to extubate patients, and we do so very quickly in the operating room compared to the ICU. It's a very different environment when we're extubating. It's much faster paced, but we're turning that anesthesia gas off, turning our oxygen to 100%, reversing the paralysis, giving more antiemetics, getting our longer acting pain medicine on board for when those patients wake up so they don't feel pain, and making sure that that patient is breathing, awake, vital signs are stable. We'll
Mhm.
extubate that patient, take them to recovery, go see the next patient, rinse and repeat, and come up with an anesthesia care plan for that patient based on the surgery, their comorbidities, all of their previous medical history. Go back to the operating room, get it set up, and just keep going. And this is what we do. And it's very exciting because every patient it requires different medicines. Every case requires different techniques and different skills, different procedures, different airways, different blocks, I mean, everything is different for every case. So it's very fresh. It's very
Mhm.
exciting, very new every day. And
Yeah.
it's
That's
wonderful. It's a great career.
when I took care of my mom last year for her health. She had to have surgery, and before, so her main anesthesiologist or anesthesiologist provider was an CRNA. And
Yes.
I remember, so she came in because I was by her side and I met it was it was like a 6-7 hour surgery. So it was very big, nerve wracking and everything. But I met all her team as they were coming in. You're like getting ready for surgery. Everybody is coming in. I'm your nurse. I'm your nurse here now. I'm your nurse in the OR. I'm your CRNA. I'm your, attending anesthesiologist. I'm the
Yeah.
surgeon. And all these other people. So, especially for big surgeries, right? So I do remember meeting that the CRNA came in and talked to us, asked us questions about any loose
Yes.
teeth, things like that, history of anesthesia, all of those things. And then she did mention, hey, I'm the CRNA. I'll be working with an attending anesthesiologist.
Yep.
But I'll be the main provider if I have any questions or so forth. I'll reach out to him, sort of letting us know her role in the anesthesia team. And
Yes.
then I do remember that the anesthesiologist also made a brief stop by to introduce himself as well. And then post surgery, the CRNA also came by, let us know, as her loved one, let me know sort of how things went, and because there was a whole plan, like, okay, we don't want to do this, but if this happened, this is what more likely what we might have to do. We might have to intubate under
Yep.
these circumstances, things like that, just preparing us for the worst case scenario.
Yep.
And then post surgery also, hey, we did have to do this, or we didn't have to do this, and this is how it went. So we saw the CRNA and the anesthesiologist pre-surgery, but it was mostly the CRNA that we saw post-surgery because she was the one who was in the room, of course, but what you just explained and everything, for the whole duration, right?
Yes.
But yeah, so definitely a collaborating team work aspect, right? As a
Absolutely.
CA. Mm-hmm.
Absolutely. And I mean, it's also extremely beneficial to work in this environment because things, it would be great if everything was perfect all the time. But in anesthesia, particularly in higher acuity work, things do happen. And we have this thing in anesthesia called the Stanford Emergency Manual. And the first step in the Stanford Emergency Manual for any kind of crisis you can think of is to call for help, right?
Mm-hmm.
With the anesthesia care team, you have guaranteed help right then, right there. You have extra hands, you have an extra brain, you have everything. Just there's people available immediately for you when an absolute crisis emerges, right?
Mm-hmm.
We all know what to do. Everyone's trained very well. It comes to a point where you just need people. You need people to help work. And because things are happening, someone's monitoring and managing hemodynamics while someone's getting art lines under the drapes, getting lines, getting a central line. It's just very quick work. And this model just guarantees that we have that help, guarantees that we have someone who is the highest trained anesthesia provider, a physician anesthesiologist, right? They're
Mm-hmm.
immediately available to jump into the room and to help that patient get through whatever that crisis may be. Maybe they hit a major vessel during the surgery. Maybe it was a bad trauma, whatever thing you can think of. It's a wonderful team. I've never actually had a major conflict in 5 years. One time with an anesthesiologist. We have
Mm-hmm.
such a great working relationship because we have to, right? I mean, these are the
Yeah.
people we're in and day out with. I've had conflicts with surgeons, right? I mean, but honestly, I've just never, I haven't
Yeah,
really had any conflicts
that's
with,
expected, right?
yeah, it's going to happen. If you're going into this career, you better be ready for that. But yeah, I've actually
I
never had a conflict with the PA either. The
That's
PAs are
good.
really
That's
wonderful.
good. we
So,
we tend to work well with people, obviously.
yeah,
We have to.
yes, yeah,
And I think, just a side note, I think when people are thinking about going to a profession as a provider, right? I think the tough part is when you take a PA or CAA or NP or so forth, is that we are providers, but at the same time, the assistant, whether it's in your name or not,
yeah,
part of it. I think some people, young going into profession, deciding on the profession, may look at it as, oh, I must always be at the mercy of the physician, right?
yeah,
Um, or like, I'm getting them coffee every morning or something. I don't know. Like, you're not the assistant in that sense. But I think what it does, like you said, is does allow that collaborative aspect of teamwork in patient care. And in my 4 5 years of working as well as a PA, yeah, I've had disagreements with my supervising physician. And in terms of, hey, could we do this or that? But that's just a
Yeah.
matter of, hey, because I've been following this patient a little longer, because perhaps I know the patient a little bit more.
Yeah.
Medicine is art and science.
Yeah.
So if you are the primary provider of that patient, that's your time to say, hey, because I know the profile of this patient a little better, although medicine will say, let's go for this, the science part will say, let's go for this. I think this other option will be better. And
Yeah.
a lot of time in my experience, when I do ask a physician for their second opinion or their final take, they oftentimes say, this is what I would do if I were you, but it comes down to you. I've almost always hear it comes down to you. You are the provider. You know what I'm saying?
Absolutely.
So a
Yeah.
lot of physicians, at least on my side, are not just like, okay, let me, because they have their own cases. That's what sometimes is not
Yeah.
across, it doesn't come across well, is that physicians who are supervising us as APPs oftentimes have their own cases, at least in my case, right?
Oh,
So,
absolutely.
so
Well,
it's like they're not just sitting there waiting for PAs and NPs to come to them and ask them questions.
no, and the reality is that's like within the anesthesia care team, while there's a whole campaign of propaganda against the anesthesia care team, saying essentially that providers are dependent on help. That's not what happens at all. You need to remember that not you, but the audience needs to remember that these anesthesiologists are supervising 4 rooms at a time. So
Mm-hmm.
if you as a CRNA or a CAA are asking them essentially any dumb, like if you're asking them, hey, can I give this drug, can I give that drug, that just simply doesn't happen. You'll overload that anesthesiologist. You'll become very annoying very quickly. It's
Mm-hmm.
very similar to being a PA or an NP.
Mm-hmm.
Simply cannot do that because
And
it
what that
doesn't allow.
does is that shows your lack of like you're not competent, you're
Exactly.
incompetent. Like you're supposed to be able to handle a good
100%.
majority of your cases,
And
right?
there's not a single CAA or CRNA that graduates from school that isn't able to handle these cases. So it's,
Exactly. That's
it's
the
just,
part.
yeah, it's just there's a little bit of misinformation as to what anesthesia care team is. Once you're in
Mm-hmm.
that, operating room, you are, providing the full anesthetic. You're not calling to give phenylephrine. You're not calling to give narcotics. You're not calling for really anything unless there's something that one you have a question about, like a genuine question that you don't understand. Um, and if you're a new graduate, that's going to happen. Things are going to pop up that are going to be difficult that you're not going to quite understand, particularly if it's a new type of surgery for you, as well as when an emergency happens and you really need them in that room, they'll be there. And so
Mm-hmm.
that's like, it's just an absolutely huge benefit. But yeah,
Yeah.
that's funny.
Let me dive a little bit into like specialization in your sense. You mentioned shortly, briefly earlier that you do mostly OBs. Do you get train? Is there a difference in training that needs to happen for different types of surgeries? And if so, how is that
So
structured?
while you're in school, one thing to remember is that one thing that's slightly different about anesthesia training versus some of the other professions is that we are already heavily specialized from day one. Our whole entire education is just towards this one specialty of anesthesia.
Mm-hmm. Okay.
So we're very heavily educated on all the different. Now, to us, it's such a big difference, right? Because we are only our scope is this wide, whereas as a PA, your scope is
So yeah,
this
yeah.
huge. You guys have so much you guys cover. We're very limited in our scope, right? We
Mm-hmm.
only do anesthesia, nothing else. And so during school we have rotations on obstetric anesthesia, cardiac anesthesia, trauma anesthesia. We have a month of acute pain service where we only do regional blocks for a month. We have ICU rotations. We have transplant rotations. Um, I mean, every single pediatrics, multiple months of pediatrics at major pediatric hospitals.
Mm-hmm.
Now, you're totally trained to go out and do those cases. What typically happens for CAA for all anesthesia providers is when you graduate, if you're expected to be able to do essentially everything very easily, except for um, cardiac anesthesia and pediatrics. Now you may need like a little brush up on OB, just because it's just OB is very quick and but cardiac anesthesia is a big one and pediatrics. CAAs will actually specialize. This is the one area that AAs actually kind of do specialize in is pediatrics. They'll go and work in children's hospitals, and those CAAs may never touch an adult patient for the rest of their lives. Right. Once they go into pediatrics, that is one area of anesthesia that is completely different than everything else. And I have so much respect for pediatric anesthetists. It's simply not something that I wanted to do. It was so heartbreaking for me when I did my pediatric rotation and you see these sick children. It's very hard emotionally on anesthetists to do that work. But yeah, that's a specialty. I did cardiac anesthesia for a couple of years immediately after graduating school, just because I was young and I was full of piss and vinegar, and I thought that I was going to go out and save the world. And I went and did cardiac anesthesia, and that is its own thing as well.
Yeah, I imagine.
We did have a very intense training program. It was like about a month long at the hospital that I went to work at. And then from there, you start working and you start doing the cases, and that's just kind of how it goes. It's you're trained in school, you're very prepared, but then they will kind of hone you in with an orientation onto what they want at that specific site. You already know all the skills, you can already do all the lines, all the airways, you can do everything. It just comes down to like workflow differences whenever you specialize into these different things. And during the course of your career, you just get better and better and better at everything. And but as a new grad CAA, they're absolutely prepared to go and work in any type of anesthesia that they, that their heart desires. There's no like specialization afterwards.
Okay.
Yeah.
Now that you are in OB primarily, say you want to do trauma next, you will just, from my understanding, just train on the job, right? They will just give you
I've done 2 years of trauma. So
okay.
The work that I'm doing is primarily OB, but then one thing that I'm also doing tons of general anesthesia, and as a part of being an OB anesthetist, we do emergencies, and then I also do like trauma and generals on my week of locums as well. So I fly to Indiana. So how I kind of set it up is I'll do my work at my W-2 job. The next day I get off at 7 a.m. because I do night shift. I will fly. The locums company will fly me straight to wherever locums job I'm going to. I'm currently going to Indiana, and I'll get there that night. The next morning, I start a day shift, and I'll work the entire week doing 13-hour shifts typically, doing like normal like general or trauma anesthesia. Like you said, it's very important. If I'm only doing OB, I'm gonna lose my skills, right? And I don't want to do that. So it's like great question, and it's why I've made my life this way. I do fly to Indiana to do the regional blocks that I do, to do the general anesthetics that I do, to do the trauma, to do these very high acuity sick, ASA4 obese patients that they have. This patient population they have there is very different than the patient population where I live. So you're right. It's extremely important to maintain your skills, and it's very easy to lose them too. If
Absolutely.
you stop doing some of these things, it quickly goes away. So, but
Mhm.
yeah, great question. That's actually a phenomenal question, and it like lines up with how I set up my work schedule. So I
Yeah,
love that you asked that.
I love that. I love that you'll have that W2/perm position and locum position, because they are some. I've done some locum as well. I did 3 assignment of locum and then I've done perm as well. There's some benefits to locum
Oh, yeah.
that you won't get in perm, right? The pay, of course, is obvious one. Then there's some benefits to perm that you won't get in locum. So
Yeah.
it's really I was sort of giving a rundown to one of my close friends actually this past few days ago, who's a resident MD, or one of those. I forgot which one he ended up going with. But anyways, like we're talking about locum, and I was sort of giving the rundown of like some of the benefits and drawbacks of either or, right?
Yeah.
And if you are considering one, sort of how to sort of do that math if you were if one would call it that, as far as, okay, does this make sense for me based on my needs and
Yeah.
based on the income that I can expect and rightfully ask for.
Yeah.
And like your expenses are different. In
Yeah.
locum, you don't have anything except for food, right?
Yeah.
Everything is taken care of. So it's really interesting to see. I'm seeing more and more people are considering and asking questions about locum.
Yeah.
And I always tell them, go for it. If it works for your lifestyle, go for it. Like,
Also, in
do it.
anesthesia in particular right now, my last locums assignment was 2 years where I was a
Mm,
full-time permanent person and they wanted to extend me for more time. My family just didn't want to live in that town anymore. I'm still doing locums in that town. That week a month is still in the same hospital. So I'm going on
gotcha.
3 years of locums work in the same site. There are locums anesthesiologists there that have been at that site for 6 years, I think 5 years or 6 years. So
Wow.
it's, the market is very different than it's ever been with anesthesia. A large percentage of our workforce are essentially pseudo-permanent locums. And the benefits within anesthesia for locums are immense. I mean, you get you get more money, right? So it's higher pay. You can negotiate your hours and your schedule and your contract. So you get to pick and choose what weeks you're working. You get to pick and choose your hours. Um,
Mhm.
in addition to all of that, you are a single member LLC or an S corporation typically. So a lot of your expenses for travel and for your locums work, you have to work with your CPA on this, but they're able to, set up a self-employed individual retirement account that you can contribute up to $70,000 into, depending on how much money you make.
Mhm.
You can also, there's a lot of other things that your CPA can set up for you in terms of what you're able to write off legally based on your expenses while you're traveling as a locums, your CMEs, all of these different things.
Mhm.
It's just it's an immense benefit to being a 1099, and the biggest one obviously is going to be the flexibility that it offers.
Oh,
You know,
yeah.
it's
Mhm.
phenomenal, and um, more and more of my friends are very quickly changing from permanent jobs to going and working exclusively locums, and I mean, out of my good friends, I'd say more than half are locums
Yeah.
CAAs.
Yeah. That's the way to do it. I was trying to convince my friends that weren't open to it. But when I was in
Yes.
local, I was like, yo, come on now, let's do this
Yeah.
thing. And the funny thing is, I was doing locum with a child, and none of them had a child. And I was like, "What's your excuse? Like, how am I doing locum with my whole family, and you
Yeah.
are here not married, no kids? This is like,
I know. It's crazy to me. I took my whole family with me to Indiana. Like, I mean, I flew them with me. So, I mean,
same. My
yeah.
mom's not traveling with me, so I was like, come on, y'all. Like, how come
Yes.
the one with the child and husband is doing this, and y'all are just leaving money on the table?
Yes.
Because so many of my agency are like, when they, ask, oh, there's a new job here and there. Do you want it? And either I'm taken with another position, or
Yeah.
I'm on vacation or whatever. And the next question is, do you know anyone who will be interested? I'm like, I know a
Yes.
whole lot of people who should be interested, but they're slacking. They're
I
leaving money
know.
on the
Being
table.
lazy. Yeah. Yeah. Well, that's too funny.
So getting a little bit away from serious things, what do you do for fun?
A lot of stuff. So
Yeah.
we're living in a beautiful part of Central Texas, and we live almost like we live next to the lake, and we go out on the lake often and go wake surfing. I spend a lot of time within my church. I really enjoy being around my parish. I lift weights with the men for my church multiple nights a week when I'm not working. I'm very busy with my work schedule. Obviously, I'm working all the time, but when I'm not in the operating room and when I'm not at the hospital, I like to be with my church very often. In addition to that, I do Brazilian Jiu-Jitsu. I'm an advocate for like grappling. I love the sport. I've been doing it for a long time. And I travel with my wife. We go often to go see our family. I've got three beautiful big dogs, and they're wonderful. They take a lot of effort and energy. And I go and spend a lot of time with my daughter. I have a 3-year-old daughter who is the love of my life. And she takes a lot of time and a lot of energy, and but she's perfect. And um, we're we're currently in we're in Texas, so it's like the weather is great. We're always outside. We're always doing stuff. It never really gets cold here, and so we're just constantly doing things. But what do you do for fun?
Um, Honestly, this is part of my fun, which is why I'm so excited to like get
Yes.
back into it.
Yeah.
But the other thing I do is cooking. Like I love making new food. Especially like if I can try something new or like make some of my classic. I love putting the recipes together and turning out and tasting delicious.
I love
And then
it.
yeah, it's I've been cooking probably since I was like 10 years old. And I confirmed this with my mom recently because I was like, I remember me burning myself a little bit and her freaking out. And I was like, hey, but the food is ready though. Like, why
I got the job done, Mom.
stop freaking out? I'm
Yeah.
alive.
Yeah. That's
you
too
know,
funny.
I'm an outdoor person, like hiking, going on walks, anything that's outside, you got me there,
Yeah.
especially if it's warm. I'm not a cold person.
Yeah.
However, I recently moved from California to Michigan. So
Oh,
I know.
yeah. I'm sorry. I'm sorry. Oh,
So it's I'm like trying to find myself in this new environment
yeah.
based on my interests and so forth, and me being like an outdoor, like I was born in West Africa in Benin Republic, so like the sun and I have a very intimate relationship. and
Yes.
and
Michigan is. Yeah.
so it's interesting. Everybody in all my family say, are you okay? I'm okay. You know, the funny thing is it's actually not as bad as I was ready for,
Yeah.
right? Let me not jinx it, we're only in January. But and even like my husband and his family agree that like back like maybe 5-10 years ago, what they are used to is that we will have feet of snow on the ground. Right now we have
Yeah.
no snow. A few days ago it was like almost 50 degrees, and my family and I went for a walk and I felt like a human. I was like, yes,
Yeah.
Lord, thank
Outside. Yeah.
you.
That's
So
awesome.
trying to find, things that I can do in this new environment that's not too cold. I'm like, I'm
Yeah.
okay putting on a good sweat and going for a walk. I'll do it.
Yeah.
And
Yeah.
it's very flat over here. Michigan is flat. There is no hills or mountains or anything like that, which are
Yeah.
all things that I'm used to where I was born and raised, and also in California, of course.
Oh yeah.
So I'm excited for the spring. I'm going to be out and about in the spring.
Every day. That's the goal. Once it gets warm, I mean, and it was the same boat. I was in Indiana, right? And once it
Yeah.
gets warm outside, you got to get outside, get that sun on your skin. Um,
Yes.
and
Yeah.
so much, especially once you come off maternity leave, when you go back to the hospital, you're going to be going in when it's dark to get in there, and you're going to be leaving when it's dark when you leave. And
Exactly.
that can be very
Exactly.
difficult.
Yeah, yeah. So just navigating, but it was needed for us. We have no family in California.
Yeah.
So it was just me, my husband, and our baby. And with the second one on the way, it was just like, okay, we gotta get close to family.
Congratulations. Oh yeah,
Thank
yeah.
you.
It's gonna be much better. You have a growing family. And I mean, that's the same reason we moved to Texas. My mother's
Yeah,
down. And so it
yeah.
just makes it so much easier when you have family around with children.
It really is. I
Um,
mean, what's the point of life if you're not with the
yeah,
people you want to enjoy with, right? So
exactly.
being in
Exactly.
a nuclear family is fantastic, but just having that extended family nearby, it's like a bigger love. It's like more people to love on, and more
Oh
people
yes.
to love on you. So it's like,
Yes.
why not?
And people to babysit when I want to go out to dinner. So
That part,
it's
that
great.
part. Are you kidding me? Like my daughter
Yes.
just spent like a few nights at my parents-in-laws, and they're like, and they love her. They're like, I mean, of course, they're like, can we come get a grandbaby? I was like, you don't have to ask.
So
Come
whenever you
get
want. Yes.
You never had to ask. Come get
Yeah.
her.
Yes.
I'm like, and she's 2. She's like on that toddler stage now where it's like she and I are crashing. I'm like, I didn't know it's gonna start this early because when I'm around, she wants to push all the limits. Because
Yeah.
I'm usually like I'm the softer parent, right? So
Yeah.
up until now, I let her do everything. Like even when I was pregnant with our son, she was climbing on me, jumping on me, and my husband was like, are you okay? I'm like, I'm fine. I'll tell you if I'm not, right? So
Yeah.
now she's used to me just letting her run wild and do
Yeah.
what she wants. And I'm like, okay, all right, we gotta reel it in a little bit because you are doing too much.
Turning into a wild woman. We gotta be careful here. Yeah. Yeah, we're in the same
Exactly.
boat with our daughter. But yeah, that's funny. Well,
Yeah,
yeah,
yeah.
it's
But
great.
you said your daughter is 3 years old, right?
Yes, yeah,
Yeah,
she's
so
3.
you are the toddler stage too.
Oh yeah.
Yeah.
She's running around today at church. She refused to come in. At one point she wanted to go outside and play, and so she ran outside and started climbing the trees. And I had to go
Fantastic.
outside and get her out of the tree, and her leggings are covered in splinters and like it was, it's just it's a tough stage. They said the terrible twos, but no, the threes are
It's
different.
not just two. I'm realizing it may start at two, but like I have cousins who are like 4, 5, 3, and it's like it hasn't ended yet. So I'm like,
Yeah,
when does this end?
it
Because
keeps them. Exactly.
any
And that,
parent listening or future parents, just know it's not just two. It starts at two, but only God knows. We're gonna tell you when we find out when it ends, because I don't know yet.
it goes forever. That's funny. Yeah. But yeah,
But no, that's fantastic. I'm glad you still keep up with and as providers, as people, we just have to, yeah, we do our work but enjoy ourselves as well with family and so forth. So
absolutely.
that's very important. Any future goals professionally?
The biggest goal, to be honest, yeah, once I have like I'm at a point where I feel like financially I'm going to be comfortable to be able to do so. I think I'm going to transition to full time. Well, not full time. I'm still going to work in the operating room, but nearly full time educational work. I'm going to try to transition to just teaching. That's like an ultimate like goal as a professional. And that's going to be essentially my retirement, right?
Mhm.
There is a plethora of jobs available to teach as CAs, but right now, just while the market is the way it is, I'm going to continue to work as many hours in the operating room in the perioperative setting as I can, and then as I age, I will transition to a more of an educator role as I get older in my career.
And that
Um,
makes sense. Yeah.
yeah,
Yeah.
but other than that, nothing too terribly exciting. One thing that as a profession would be wonderful to see is we and it's a huge goal of mine as well to kind of help with this. Hopefully, um, they're currently CAs can actually practice in all 50 states currently, but only within the Department of Veterans Affairs. Within the Department of Veterans Affairs, our pay has actually been misclassified, and for the first time, really, since I've become a CA, and I think ever, we're kind of getting on this, and we're kind of addressing this issue. To get the CA pay was actually equivalent and misclassified to what a respiratory therapist makes. Um,
Oh, that's a big difference.
it's a huge difference. And that's
Yeah.
why, as a result, there are 0 CAAs that are working permanently in the Department of Veterans Affairs, despite being able to work in all 50 states, simply because it's when your pay is miscategorized, you're not going to go and work there. So the ultimate goal is just to get the CAA pay categorized as an anesthetist with the CRNA colleagues, because we make the same as CRNAs everywhere else in the world.
Hmm.
And then we might be able to get some CAs in the VA, and then maybe eventually, because I live in Texas, my mom's about an hour south. My dad's ranch, my stepmom, I hope all my brothers live in Montana. And the ultimate goal would be to go home professionally, I guess, go home to Montana and work near my family. That's the ultimate dream goal professionally. But that's it. But yeah, that's nothing exciting. I don't have any like crazy lofty, lofty goals other than
No, and
that.
that's totally fine. Like
Yeah.
once you are content and happy in what you're doing, that's the goal, right?
Yeah.
That's the golden spot to be in. So absolutely. And what is your any final like word of advice to future CAAs or anyone considering your profession?
Absolutely. The biggest thing is just do it. Okay. Like don't wait. What I get so many messages, so many DMs, so many comments when I go live, kids asking me if they're competitive or not. You know, the information's out there. You know what you need to do. You know you need to have good grades. You know you need to have good test scores. This isn't rocket science. If regardless, apply.
Mm-hmm.
Regardless, apply. Just go for it. Apply, guys. Do it. This is a phenomenal career. Like you'll be very happy. I promise you. Just don't let the naysayers scare you away from applying. Put in an application. You never know what's going to happen. That's my advice to everybody out there. And that's really it. Just don't doubt yourself.
Yeah. Finally, because I think you are the only profession I've interviewed here that is not able to practice in every state. So,
Yes.
um, any resources for aspiring CAAs as far as where to go, trusted links and so forth to say, hey, this is the updated information on the states that I can work in as a CAA.
Absolutely. We have a website called anesthetist.org. That is our
Okay.
professional website for the American Academy of Anesthesiologist Assistants. There's also a Discord for pre-CAAs to get into CAA school. Get on that Discord as well. My page is good. There's another CAA. Her name is Shabeli. She is on TikTok and Instagram. She's a very large CAA influencer. She's wonderful as well. But the ultimate resource is going to simply be the American Academy of Anesthesiologist Assistants and anesthetist.org. All the information you want to know about the career, about the profession will be on there. Finally, the American Society of Anesthesiologists always puts out good information on our career. I've never noticed they're always very honest. They are very black and white and very transparent about CAA scope of practice, states, limitations, where they work, training. Everything has been honest that I've ever seen come out of the American Society of Anesthesiologists website and their organization. So, and as a matter of fact, like we support them and they support us. So, those are the resources I would look at. And that's it, guys.
All right. I think we covered a whole lot,
We
and
did. Thank
I
you.
think
This is
we
wonderful.
did.
Thank you for having me so much. This was so fun. I appreciate you.
This was very fun, and thank you for taking the time and joining. I appreciate, like I said, I was giddy learning. I was like, listen, I'm not even gonna search anything up besides what I already searched up. I'm just going to dive in with this like live interview and just figure out and learn about what this man does and how he got into it and just the profession in general. And I love, from one newer profession and growing profession to another, right?
Yes. Yeah. Thank you. Well, it's been wonderful. Thank you for having me. I really appreciate you. Your
Absolutely.
page is, I love your podcast. It's amazing.
Thank
And
you.
again, I hope you have a great day and thank you again for having me, man.
Thank you. Have a beautiful one.
You too.
Bye.
Bye bye. Bye bye.